Hello, my name is Adam Faye, and I'm an assistant professor of medicine and population health here at NYU Langone. I'd like to thank Dr. Simona Bhattacharya for a truly outstanding presentation and for highlighting an extremely important topic. We know that our patients with inflammatory bowel disease are at higher risk for venous thromboembolism or blood clots. It's incredibly important that they receive prophylaxis during hospitalization, as data has shown that can decrease risk for blood clots during hospitalization and even perhaps in the immediate post-discharge period. When we look to our surgical and oncology colleagues, we know that patients who are at high risk for blood clots may actually benefit from extended pharmacologic prophylaxis. So that means giving prophylaxis even after the hospital discharge for an additional couple of weeks. Within the inflammatory bowel disease patient population, we look to address a similar question. In the first study, we really wanted to look at the timeline for blood clots to occur after initial hospitalization. And as Dr. Bhattacharya mentioned, 90% actually occurred within the first 60 days, and what really the majority of hospitalizations due to blood clots were within the first 30 days after initial discharge. So that led to the second study or question looking at, well, is it beneficial to give all of our patients with inflammatory bowel disease who are hospitalized additional prophylaxis for 4 weeks after their initial hospitalization? What we looked at specifically was a novel oral anticoagulant, rivaroxaban, for 30 days after discharge. We looked at a few different measures, one being quality-adjusted life years, and we found that actually giving a novel oral anticoagulant for 4 weeks improved quality-adjusted life years. When we looked at the number needed to treat to prevent one additional blood clot, it was a staggering 78. And we looked at the overall cost, it was $185,000 per quality-adjusted life year. Traditionally, with cost-effectiveness analyses, the cutoff is usually $100,000 or $150,000 per quality-adjusted life year for it to be cost-effective. So where does this leave us? As Dr. Bhattacharya mentioned, it really should be an individual risk decision. So patients who are at higher risk will clearly benefit from this and should be considered for extended prophylaxis. So that includes potentially older patients, patients who just had a surgical intervention, who have ongoing disease flare, who perhaps are on medications that increase their risk, such as corticosteroids. And really, where the future data needs to be is how these risk factors kind of work together to increase a patient's individual risk. So if we can really model a patient's individual risk, we can really pinpoint whether specific patients should benefit and should receive extended duration pharmacologic prophylaxis. This will really help influence guidelines in the future, and I'm hopeful that we'll have that data soon. Thanks so much for listening.